So again, for those of you joining, it's going to be really based on chapter 20, kind of updates to opioids for pain relief for fibromyalgia from the FibroManual. Other brief reminder, I'm happy to answer questions. We'll have like a 15-20 minute talk and then 15-20 minutes or however long to answer questions if anyone has any. If they come up for you and you want to, hi Anne, if you want to leave them in the chat, then when we get to questions, I will try to do my best to answer them, with the caveat that I can't really give specific medical advice, but I can try to answer things more broadly. Yeah, I think that kind of covers the intro stuff. So because you guys are here, anybody want to guess, and you can put it in the chat, what kind of percentage of folks with fibromyalgia are prescribed chronic opioids? Is it like 10%, 20%, 70%, 100%? Obviously not 100%, but I recently read a study that kind of looked at generally how many, when you look at, you know, the fibromyalgia population in the US, how many folks are on opioids. Oh, you must have read the book, Robert. It's 40%. So very good guess. Although Mary, I mean, honestly, that was from a couple years ago. And as we know, opioids are very, very out of favor right now, as far as using them for chronic pain. So it might actually be less, because I think there's more and more of the phenomenon of patients having opioids being taken away because doctors aren't as willing to prescribe them. It seems like each year they're kind of less and less willing to prescribe them. So I'll kind of talk a little bit about why that is, some of which, you know, won't be news to anyone, but I think it's important to kind of try to understand that there are some reasons why opioids might not be the best choice for chronic pain management. But I've always advocated that until we have better options, and we don't really have great therapeutic options to reduce fibromyalgia pain, I feel like they need to remain in the toolbox in some way, shape, or form, but trying to use them in the best possible way and the safest way. So that's kind of what I thought I would talk about, and how my approach to opioids was maybe a bit different than what you might be familiar with. So hi everybody. So I'm going to dive in now. So, okay. So there are some problems with chronic daily opioid use, and the higher the dosage, the more problematic these are. So the first is tolerance, and that means over time, the body requires this higher doses to get the same effect. So somebody, you know, might be on 30 milligrams total of morphine daily for a few months, but then that's not working as well. So it has to go up to 40 and then 50. And it can just kind of keep escalating until you reach a ceiling where it's just, no matter how high you go, it's not really going to give any more benefit. So that's one limitation, right? Is that you're going to have to dosage escalate, as we call it. The second is dependence, and this is different than addiction. I'll delineate that in a moment, but dependence is just the physiologic mechanism so if you're on a medication that causes dependence, if you stop it, you experience withdrawal symptoms. And, you know, there's other medications that have that experience. Anybody that's stopped an antidepressant suddenly, like something like Cymbalta, is miserable to stop suddenly, because your brain will experience these zaps and all sorts of other symptoms. And that is an experience of dependence, right? So your body's having these withdrawal symptoms when that medicine is taken away. Not all medicines do that, but opioids are kind of the classic medication that does that. And that can be really problematic, right? Like you lose your medications, run out, you experience withdrawal, and it's really miserable. So that is very different though than addiction. And what often patients will say is like, well, I know I'm addicted to them, meaning like if I stop them, I'll have withdrawal. And I'm always kind of saying like, no, dependence is like the physiologic phenomenon of experiencing withdrawal when it's taken away. Addiction is actually abnormal behaviors around a medication. So unable to control your usage of a medication, that's a sign of addiction. Using it to change your mood, using it kind of seeking euphoria, seeking a mood change. It's those behaviors around the medicine that is addiction. And the physical experience of withdrawal is related to dependence. So it's important to kind of separate those, but dependence, 100% of people that are taking a chronic opioid will get. And by chronic, I mean every day. Only between 1 to 8% of folks that are prescribed opioids for chronic pain will develop addiction, meaning those abnormal behaviors around the medicine. It's not, 1 to 8% is certainly not zero. It's definitely something to be taken seriously, and that is absolutely a risk with these medications. But I think the way that kind of the media or doctors sometimes will talk about opioids make it sound like 100% of people that are taking them will become addicted, will have these abnormal behaviors around it. And in my experience, that number is actually very, very low. Most folks that are taking opioids to manage their pain use it to manage their pain, and they are responsible with their medicines and they treat them carefully and they understand the risks. And, we can't ignore the risk of addiction, but I also think we can't assume that 100%, we can't treat everybody like they're an addict. And I think the stigma around pain medications makes a lot of patients taking them for pain feel like addicts and feel stigmatized, and that is very frustrating and is really not based in reality. But, if we could come up with a medication that reduced fibromyalgia pain and did not cause addiction and did not cause tolerance or dependence, of course, that would be much better. But again, until we have better options that are widely accessible and are effective for everybody, or most people, because we have things that help people right now, right? Like low-dose Naltrexone helps some folks, cannabis helps some folks, but we don't have anything that's sort of like that silver bullet, like, hey, this is definitely going to reduce your pain. And the closest that we can come to that really are opioids, but they're this double-edged sword, right? They can help, and they can help for a while, but over time, then they have these risks. And the final one, and the one that's really challenging, is if you are taking an opioid chronically, meaning daily use, and particularly higher doses. So we're talking, above about 100 or 120 milligrams of morphine or morphine equivalents. Over time, what can happen is you can develop opioid-induced hyperalgesia, which basically means the opioids themselves are worsening pain. And we know that this happens kind of in two ways. Two pathways leads to that. One, chronic use of higher doses of opioids activates glial cells. And we know activated glial cells, the immune system, the immune cells in the brain, generate neuroinflammation, and that generates pain. So what we see is in fibromyalgia, we're already dealing with neuroinflammation. We're already dealing with activated glial cells. You add chronic daily high-dose opioids on top of that, and the neuroinflammation gets worse, or it can. So that's sort of the one of the mechanisms we think behind why opioid-induced hyperalgesia happens. The second thing is, and this is newer, so everything I've just discussed is covered in the FibroManual. But the newer thing that we have discovered in the past few years is that when you are on chronic opioids, particularly higher doses, it can actually change the shape of the opioid receptors. So the opioid receptors in our brain change shape, and the new kind of different shape, instead of reducing pain transmission, meaning inhibiting pain, it actually has the opposite effect. They turn into excitatory configuration. And so rather than lowering pain, they're actually amplifying pain. And this is where opioids become basically a problem, right? Like they're not helping pain at all. And in fact, they are conceivably making pain worse. But the challenge is if you are on opioids and you say, okay, I'm worried that maybe they're making my pain worse, what you have to do is taper off of them. The only way you can know if it's the opioids that are making your pain worse is to come off them. And the process of tapering opioids causes withdrawal symptoms. And one of those withdrawal symptoms is increased pain. So you end up in this like really rock and a hard place situation where patients can feel understandably really afraid to taper their opioids because they're worried about withdrawal symptoms, they're worried about increased pain. But you have to kind of get through that period and then actually give your receptors about a 4 to 6 week period where they're not exposed to any opioids before you can actually really tell, well, were the opioids making my pain worse? And interestingly, in some studies they've done, when they take not just fibromyalgia patients, but any chronic pain patients that have been on opioids chronically, when they take them off opioids, there's this initial period where their pain is worse, but then often actually pain gets better and is often better than it was before they started opioids. And it's kind of that phenomenon that I think makes, hi from Japan. I think that makes a lot of doctors really feel additionally negative around opioids for fibromyalgia pain, because what they see is maybe those patients are on opioids and they do well for the first 3 to 6 months. Then the doses start having to be escalated. Then it actually seems like maybe things are getting worse. So from a physician's perspective, it kind of is like, well, it seems like what I'm giving you is actually making things worse. So we should pull that away. And then add on top of that the risk. I mean, there is a risk of developing addiction. And in the era of readily available fentanyl on the streets, which is highly, highly potent and can result in death, like it's like opioid overdoses are problematic and they're real, and addiction is real. So doctors, I think, are stuck in this rock and a hard place. I think patients are. And so what I've kind of tried to do is pull back and say, like, okay, what are some better ways to use these medications that won't cause the opioid-induced hyperalgesia? They won't cause the tolerance, the dependence, and have a lower risk of addiction. So what I have found is that if you don't use opioids every day, if you only use them intermittently for pain flares, and by intermittently, I mean about a third of the days or less. So like out of a month, only like your 10 worst days would you utilize an opioid. When you're using them intermittently like that, you actually can pretty much avoid, for the most part, tolerance, or at least if tolerance develops, it takes much longer. Like rather than taking 3 months to develop, it takes 3 years. So you can be using ongoing lower doses, right? And the lower doses are going to be safer. You have much lower risk of dependence because you're not taking it every day. So your body is kind of used to, well, some days I get an opioid in my receptor, some days I don't. And so there's very little withdrawal phenomenon. With that intermittent dosing, I have not seen patients develop worsened pain or hyperalgesia. I couldn't find any studies that have really compared this, but just my anecdotal clinical experience is it doesn't seem to worsen pain. And you do seem to get sustained ongoing benefit from opioids when you're using them just intermittently. So that is one way that I have found to kind of get the benefit of opioids with lowering the risks. Doesn't make the risk zero. You can still certainly accidentally overdose. You can still certainly develop abnormal behaviors, or you can develop addiction, but it's just it's a much lower risk. So if we're kind of looking at that risk benefit, I think it starts to shift in a good way. It can be tricky from a patient's perspective, and I hear this a lot. Patients are like, well, I hurt every day. How am I going to know what are my worst days? And that part is tricky, but I think most of us can recognize the phenomenon of flares and pain flares. And over time, as you get to know your body and kind of know what a flare feels like for you, people do start to kind of learn, like, okay, yeah, I know I'm going to be like walking a lot. I'm going to be going to Costco on Friday. So like possibly on Saturday, I'm going to be feeling, yep, I feel worse on Saturday. I'm going to take one of my short-acting opioids. So intermittent dosing and keeping the dosages low, that's one way to get around most of those issues. The second thing is, no, and I'm going to answer that actually, the partial agonists. So the other newer way that you can reduce opioid-induced hyperalgesia, which was not really very well known when I wrote the book, is utilizing ultra low doses of naltrexone. So naltrexone is an opioid blocker medication. And most of you are probably familiar with low dose naltrexone, which is an agent that reduces inflammation, reduces neuroinflammation, and reduces fibromyalgia pain. I recently did a video about low dose naltrexone for fibromyalgia, and in that I also talk about ultra low dose naltrexone. But naltrexone is an opioid blocker. If you take it in microdoses along with an opioid, it seems to prevent the development of opioid-induced hyperalgesia, and it seems to prevent some of the development of tolerance. So you actually get more benefit from 20 milligrams of oxycodone over time, and you don't have to dosage escalate. And I've actually found this clinically. I had a patient that came to me specifically because he knew that I was actually kind of familiar with low-dose naltrexone, and we experimented with ultra-low-dose naltrexone, and this is like 0.35 milligram dosage. And he was somebody that really quickly developed tolerance to opioids. But with that just tiny little bit of that opioid blocker, it was enough to prevent that. So he was able to kind of get sustained benefit at a low dose. So that's an exciting thing that we can add in there. Then Anne brought up the very good question of partial agonists. And so the classic one when we're talking about that is buprenorphine, which the brand names are Suboxone or Subutex, and it's a sublingual medication. It's also available as a patch form. That's the Butrans patch. Typically, the Butrans patch is used for pain management, but I had a lot of patients not be able to tolerate it because it seemed to burn their skin. So more frequently, we've been kind of moving to using the sublingual form of buprenorphine as needed for pain, like replacing what we might use something like oxycodone. The benefit of a partial agonist is because an agonist means basically like activator. So rather than morphine, which comes in and totally activates the opioid receptor, a partial agonist like buprenorphine comes in and activates the receptor, but much more mildly. And it activates it enough to get a pain benefit, but not enough to really seem to trigger the hyperalgesia effects, the tolerance effects. Certainly there is dependence. That is pretty much the same with buprenorphine. But it seems to have less of the other types of risks. And we think actually less euphoria, less less positive mood benefits. You don't get that feeling of kind of high as much from buprenorphine, so it is less likely that somebody becomes addicted to, meaning abnormal behaviors around buprenorphine. So it's only recently, I would say in the last few years, that it's really moved into kind of mainstream pain management. And part of the reason why it's been so slow is there's been a lot of concerns. It's primarily designed and primarily used for addiction. It's primarily used to help people who have opioid use disorder, and whether that's from prescription opioids or heroin, not really very available anymore. Now it's really fentanyl available on the streets. Whatever the opioid is, buprenorphine can be taken daily as a maintenance dose to reduce cravings for opioids. And that's basically how it had been used since it was, came to market. And there used to be this misconception that you had to have like an addiction medicine credential to prescribe it. You actually didn't. You could use it off-label for pain, but a lot of doctors didn't know that. Now, very recently, that has been changed where you don't even need a special DEA license to prescribe it for addiction. So I think it's going to become more and more commonly used, which is great because it's a much safer, I think, in the long term, and a really good choice. And I'm hoping that they'll develop kind of some other partial agonists as we go forward, and that could be something that we start to use more frequently. Another difference from what I wrote in the book is we used to use a lot more methadone for chronic pain. Methadone also is used to reduce cravings in opioid use disorder. But when used for chronic pain, because it has the secondary effect, it also activates NMDA receptors, or actually blocks NMDA receptors. Because it has that secondary effect, it also is not associated with as much of the negative issues, hyperalgesia, dependence, tolerance, some, but less. However, methadone is a much trickier medicine. It's very kind of problematic and hard to dose. It has a very long half-life. So it's actually kind of a higher risk medication. It also can affect heart rhythm. So we've really moved away from using methadone for chronic pain management. Like I can't remember the last time. I think I had one patient maybe that was on methadone still for chronic pain, but very infrequently. It's still used for opioid use disorder, but even that is really being replaced by buprenorphine because buprenorphine is such a great medicine. So I think it's going to be used more and more frequently for hopefully for fibromyalgia pain. So if you are running into an issue where your physician is just like, nope, I'm not going to prescribe any opioids for you, you can ask about like, well, what about buprenorphine? You could also say, what about a partial agonist? I've heard about that, and see if they might be willing to consider that as a pain management option. So the other thing is if you are struggling to find, I would say, if you're somebody that is experiencing that opioids, you've been on a chronic dose and it's just not helping you as much as it used to be before going up on the dose, it's worth asking them if they might be willing to add ultra low dose Naltrexone. So to review, the newer kind of ways, better ways to utilize opioids are trying to avoid daily usage, trying to keep the doses lower in general, and using intermittent dosing, so where you're taking it 30% of the time or less. Adding ultra low dose Naltrexone also is a newer option that seems to limit some of the negative chronic effects of opioids, along with using more partial agonists. So that is kind of the review of new things that I wanted to talk about.